call the December 11th, 2024 meeting of the Monroe County Board of Health to order. We do have more than a quorum.
There she is. Yay.
There's Sarah. Okay, great. So we're all here. First order of business is approval of our minutes, and we're going to start chronologically. So we'll do our September minutes first, which are still unapproved. If everybody's had a chance to read them, I would accept a motion to, what, do you have corrections?
Yeah, under public comment, C, it says members of the public, and it identifies them, and candidate for county council identifies them. It says spoke in support of the recently closed Futures Planning Clinic. They didn't speak in support. I think we should take the in support out of it, because the sentence continues, if it's spoke of the recent closed Futures Planning Clinic and the services it provided the community, particularly for marginalized groups, and expressed concerns about transparency. I think that in support, this should be taken out.
Okay.
But I think it's worded correctly.
Oh, you do?
Because the recently closed modifies Futures Family Planning Clinic, because it was recently closed
It was.
at the time, had it been closed? Right, it was closed as September 19th.
Yes.
Okay, so recently closed Family Planning Clinic, and they were speaking in support of the clinic.
They were speaking in support.
Right, so they weren't speaking, Kay, if it were worded, they spoke in support of the closure of Family Planning Clinic, I would totally agree with you. But, and
I agree with Aurora. As you were reading it, I was thinking they did actually speak in support of the recently closed clinic.
they weren't supporting the closure
Yeah.
of the clinic.
Okay, I took it, they were supporting the closure when I read it, but whatever.
All right, so we'll leave it as it is. So in that case, did you have other corrections? So no, anyone? Motion to approve? Thank you.
All second.
Been moved and seconded to approve the minutes from the September Board of Health meeting. All those in favor, please say aye.
Aye.
Opposed? Motion passes. Right. The November meeting minutes, the last month's minutes. If everyone had a chance to read those, I would accept a motion to accept those minutes.
I'll make a motion to accept the minutes for November 21st.
I'll second.
Thank you, Lisa. Been moved and seconded to accept the meeting of the minutes of the November meeting. All those in favor, please say aye.
Aye.
Opposed? And it's part approved. Public comment. Do we have anyone? I see. Shelley, you're actually on the agenda, so you are public, but we're going to hold your comment for a moment. Commentary. Do we have anyone? You see anyone? No. Okay. Seeing none, then we'll move on to our next item, which is department updates. And we have with us tonight Shelley Salieve from HealthNet. So Shelley, the floor is yours.
Thank you. I really just wanted to stop in. First of all, this is kind of an all-new board since I have been coming to the meeting, so this is new. So I do want to meet people. But mostly, I just want to thank you for the ongoing support that the health department has given the HealthNet. The Monroe County Health Department has given HealthNet, but also volunteers in medicine. We've been receiving funding for you guys, from you guys for, I think, almost since the opening of the demo clinic. I have to go back and look at the records.
How many years ago was that?
That would be 17,
How did I
almost
say that?
17. Mhm.
Call since the beginning.
Yeah. A lot. Let's see. prenatal care because of the health clinic and the health department. And so we're so grateful for your support and your ongoing support. And really, I just wanted to come say hello, meet you guys, and thank you very much.
I think on behalf of all the board, we're happy you're here doing what you're doing. It's a really valuable service for the community, so thank you.
We love what we do. I have a very special little team, and I'm very proud of them. And we do some great stuff, and I know you know a lot of them.
Yeah.
Thank you. It's nice to have such a supportive organization.
Yeah.
It's come a long ways from Raj Hadawa's inception.
That's right. It really was.
It's expanded, but I was talking to Raj about it, a few months back, and he was just delighted to see that it was able to expand to include people who do have Medicaid and Medicare and really to see anybody. So but we still provide all those services that we did at the dental clinic, behavioral health, and we try to do dental. Again, if you know a dentist who's interested, let us know. We're looking for a dentist.
Yeah, and the evolution to a federally qualified health center allowed you to provide a lot of more services, and for some reimbursement allows other programs to exist. So, because Volunteers in Medicine was worked basically on donations.
It's a center.
All donations, yeah. It was amazing that it functioned as long as it did.
And I do think that's a reflection of our community that we live in. I really do. We were able to do a lot for their.
Yeah.
And that was really all I have.
Well, great. Shelley,
Thank you.
thanks. Yeah.
Thank you.
Thank you.
I'll let you.
Happy holidays.
Thank you. You too.
So,
I will. Thank you. You too.
Okay, Nick is not here, so Indiana Recovery Alliance, Nick usually comes to speak to us every year. He's packs a lot of information into a very short period of time. But
Well,
maybe he'll,
got plenty of business.
yeah, so we'll go around that for now to Lori's administration report.
Mine's really pretty brief. We've been busy, but not a whole lot has changed since the last time we've met. So some updates on our new positions. So the Health Services Director position and an Assistant Registrar and Vital Records positions were posted 1 week ago. So we've received well over 30 applications for the Assistant Registrar position. And just one for the Health Services Director so far.
Goodness.
And unfortunately, that candidate does not meet the requirements. Looking at seeing what other, I can post that on a state site where all of the local health departments have access to see open jobs and see if we can start increasing some activity that way.
does it also go on Indeed or any of those?
Indeed and LinkedIn.
Okay.
And then the county website.
What do you remember what medical websites you could put it on?
Yeah, that's a good thought.
So you were looking for basically.
Does the Indiana Hospital Association have a job board? Because that might be a good place for it.
I'll check on that.
It's we're looking for a nurse, correct?
A nurse with
Administrative
and managerial.
and managerial experience.
So I'm wondering, is there a statewide nursing website that might also be a place to post? And it should probably, if we haven't sent it to IU, it should certainly go on their website for job posting, because why not use our connections?
School nursing, yeah.
Yeah, and we have,
Coach them.
we have school nursing and it's statewide, and yeah, we should be using all of those places to post.
I'll check on all of those. Let's see, been doing phone interviews for candidates for the Director of Public Health.
By the way, I'm sorry, can you just tell us, you said you've had over 30 applicants for the vital records position. What percentage of those fit the criteria? And,
Probably maybe half.
oh, well, that's a lot. That's good.
Yeah, so it's a mixture,
Okay.
but the qualifications are different as far as educational requirements and experience.
But I was just wondering if any of them were viable candidates. Because
Yes.
often we don't get viable candidates in positions.
Design records positions always seem to bring in a lot of traction.
Good.
So, yeah, I think it's gonna take some time to sort through all of those.
Thanks.
So the Director of Public Health Preparedness, just doing phone screens right now. I'll be looking to transition into in-person interviews starting in January. And interviews for the harm reduction specialist are still ongoing at this time. So all of the core service data for the department for the first 11 months has now been submitted. I will submit the remaining data for December and January of 2025. I'm hoping, I believe that the state will update their website on Health First Indiana to be able to reflect some of those metrics. In 2025, we will now start submitting our core service data for environmental services and vital records. We have not been doing that currently. It hasn't been on the portal, so they've now got it. So we'll be adding those metrics next year. Mike in environmental is working with his team on changes to our fee code. We need to update fees for holding tanks and still working on changes to Chapter 365 for the on-site sewage systems. Our proposed local changes are still in the process of going to the review panel at the state. So we're still just kind of working on some of those changes at this time. But this will be coming to the board in 2025 as we update our local codes. Indiana Department of Health is discussing adding to our DIS district for the grant. This could potentially be an additional 4 counties.
Do you know which 4?
So they're talking about Hendricks, Morgan, Johnson, and Shelby. So from my understanding, what's happened is Marion.
I was inundated. Marion County can't.
And they pulled out of the grant, so they are now just using HFI funds. So that means the donut county, so they are just funding and paying for services in Marion. So now they've lost the coverage to those surrounding counties.
Which other counties?
Hendricks, Morgan, Johnson, and Shelby. So I've been speaking with Miranda to try to have a conversation because we would have to have have to add to our DIS if we're going to get.
Unless something has radically changed. There's usually not a lot of syphilis in those in the donut counties. It will primarily be chlamydia and gonorrhea that perhaps they can just do morbidities on rather than initiate. But yeah, you need.
Since you're carrying on a discussion, you probably ought to speak up a little bit.
I'm sorry, but yeah, you're gonna need more people. You're gonna need more people. Even just to do the data entry, even if you don't do case investigations, you're gonna need more people for the data entry. Wow.
Do you know what that population base is?
No, I mean, Hendricks, I think is around 130,000, but I don't know the population size of the other counties.
And we have to look it up, but my recollection is their STD morbidity isn't enormous.
But it's out there.
It's, everywhere, everywhere. Yeah, it's not non-existent.
So we'll be getting the grant application soon and then hopefully be able to find out about whether that would include additional funding and what changes. So Matthew is transitioned to HFI funding, so he's just covering Monroe County now. So it's just Miranda covering the district with the grant. So we do have that part-time position filled for DIS to assist. That position is still ongoing, doing training. That's all I have.
Well, so you had a little more than you thought.
Can I ask, I'm curious, going back to the septic systems and how many we've actually managed to finish all the paperwork so that we don't lose the funding that was available, that will only go to the end of this month.
So there was 3 more that was in process of getting those finalized with the paperwork. But some of that is also just trying to get a hold of the contractors and getting through the process of the paperwork. And I know that there's been discussion of contracting so we can finish doing the work next year. But there's multiple factors that are going into actually getting these contracts approved and signed off before the end of the year.
Okay, thanks.
That's it. Okay. Thank you, Lori. Always good stuff. Thanks up. So we're going to move into old or continuing business. I want to have a comment first before we talk about the HealthNet, this is the Health or Homeless Initiative Project, I think the partnership agreement. I received, we had some questions about how many people were, maybe this initiative would keep out of the emergency room and it'd be a way to evaluate the expenses. Well, as it turns out, I received an email just this morning from Catherine Wiles, who I had spoken with prior to this, who could really provide virtually no information. She was the one that sent out that intern study that I think I copied you all on. But because those of us that were at the public health clinic, we were notified that on that particular day during the summer, when we had our tour down there, that a data analysis person was being hired. Well, as it turns out now, they have some very specific information. And this email, I sent this email early this afternoon, and I just received it late morning. So if you haven't read it, you're completely forgiven for that. Not that you need my forgiveness, but I would understand. So now they have some very specific information about who they're seeing, where they're from, what they're there for, where they live, or what they give as an address. So this information is just becoming available. They do not have statistics for November and December yet, but they will have statistics for the year. It sounds, at least most of the year. The little picture that was included was just a phone picture of a screen. And when you enlarged it, it was completely illegible. So Shelley assured us that we would have a file that has that information on it. So as we start to consider the partnership agreement for the homeless initiative, my original suggestion, the one I sent out on the email, was that we funded at the 135,000 level. They were asking for 155 because they added in the 20,000 for other medical costs at the end. It really wasn't. I think they were hoping to get that, but it wasn't necessarily that they had an expectation that we would include all of that. And I think the only way we could include it would be if we had statistics showing how effective this program is. And then the second thing is, once we have that information, to ask IU Health to partner in this program and contribute at least some level below what they're saving. And we would have statistics then to show that. I hope I've summed that up well enough. So now we can open this to further discussion.
The data was really my only concern with this whole thing. And even reading the contract, I still wonder if we want to consider changes, because quarterly reporting metrics they list several, but the one that concerns me, of those seen by Homeless Initiative team, compare with visits to IU Health ED if IU Health is able to collaborate. I feel like it is so important that we have actual numbers.
Mhm.
Historically, as you said, they can get now of how many homeless people they see between those hours so that we can show the public we spent this money, it's making a difference, number one. Here we can quantify the difference it's making. But number two, as you just said, to be able to have IU Health partner financially. So I don't know how we do that without requiring a quarterly report showing IU's not only the people that they're seeing, but what IU is not seeing, hopefully.
Yeah, I see.
You see it?
I know what you're saying.
Yeah.
The people they're not seeing.
The people they're not seeing, yeah.
I attended the meeting that they had virtually where with the new data analyst, and they were going through that. So, I mean, I feel pretty confident he's gonna do a great job pulling that information and tracking it.
Okay.
To what extent are they doing some of the work that we're going to be helping funding? This is something I could have asked Shelley. I'm not sure I'm clear on how much of this work they're already doing. They're doing some of this.
HealthNet, you mean?
Yeah.
Yes, but so this funding will be able to give the capacity to increase the nurse practitioner to a
Yes.
full-time status and then and pay for additional personnel.
I mean, that's basically what it's for, is personnel.
Yeah. Yeah.
And it sounds like also move it into Wheeler Mission, right? Aren't they physically
Yes.
going there to do this?
Yeah.
So this is an expansion, right? So that's good.
And because of the high volume that Wheeler Mission of going to the ED utilization.
And my guess would be, once they get there and become known with the clients, there's probably, like, if you think of an iceberg, probably the tip of the iceberg are those folks that were going to IU Health. There's probably going to be like a ton more people now that actually need services, and now they will be seen.
And to me, it's like, this is, you put this money in this program, and I am in favor of it, but if we put this money in the program, and then of course, the program has to be evaluated, which it will be, because we'll have some information on how many they're seeing, and also how many people are staying out of the emergency room, or how many people they're seeing. And they, as they mentioned in the information today, they can actually target people that are showing up in the emergency room and target those people early, because now they'll have identifying information, and they can identify them for treatment early on before they ever get to the emergency room. I feel like it's money well spent. Plus, one of the things that I feel like we need to do, or have needed to do, is do more outreach. And I feel like this is exactly the kind of thing that we want to do. It's providing access to care to people that do not have it in a different way, in a way that we hope is going to be more effective than just going for an emergency visit, which usually doesn't really solve any kind of long-term problems.
So I share Aurora's concern about IU Health's participation in supporting this program. On the other hand, these are people who need to be reached, and this, no matter what IU Health does, I see it as our responsibility to do the work and to make sure that these people are being cared for. When we've got more statistics, even more statistics, then I think we're in a position to squeeze
Yes.
IU Health, to twist arms, to make it very clear that this is their public responsibility and that it is their mandate as a not-for-profit to do this.
Right.
Well, now that we've got the data,
So-
sounds like.
Lisa,
I think that, as everyone is saying, we're stewards of public funds, and I think certainly this provides an excellent service for our community. I think that for me, I have no problem approving the full-time nurse practitioner, family nurse practitioner at 65,000. I think that due to the late data, getting us late data, I think the data part is something we're concerned about. So I think maybe what we do is not approve the second part, which is the outreach navigator, until maybe next year when we have data to say to the public, okay, this is the number of patients we're serving. These are the patients who have access to care. And we can really delineate, there's a difference between saving IU Health money, which some of this is about that, which is concerning, because they're non-for-profit, and some of that is their responsibility. And maybe next year we decide, okay, we're going to provide public funds for the outreach navigator. So my preference would be that we approve, I think, part of the funds or a part of the contract. We're providing access to care, but maybe not the full contract. So that's my,
well, I would argue that this is not at all about saving IU Health money, because that's
you can put that in their literature though to us.
Yeah.
Fair enough.
They did,
it's like a
but that to me,
byproduct.
that's not for us. That's not,
The purpose.
yeah, that's not.
I think it's a
I want to
byproduct.
make sure as a board that we're making sure we're holding ourselves accountable to the public as, hey, this is our motivation. So in order to actually get data, I think, I just don't want us to say, okay, yeah, go for it. I think we just maybe need to consider not approving the entire amount of funds, which I know you're trying to address that with not approving the 20,000. So that's my assessment.
And I suggested an alternate approach because I see what you're saying. My concern with that would be that Health Net thought about what they need in staffing to be successful. So I wouldn't want us to come behind and say, we're not going to fund the navigator now because it might cripple, they might not be able to do they might not be as successful without it. So that would be my only concern about this. At the same time, I still have the data. So I wonder if we can work out a way to, and I think this will end up falling to Lori or whoever is, maybe the new health services director, whoever ends up kind of overseeing this grant into next year, to really work with them monthly or quarterly on the data with a very intense data focus. Because now IU Health has that data person and they have reports. So everything we're talking about might be moot in the first quarter if that person is able to give us data and we get it. I think we just need to, and so maybe instead of not funding the navigator, we go ahead, we fund them at the full amount with the understanding that we're very serious about collecting the data quarterly. We're going to be looking at it. If there's a problem, we're going to be talking to the parties involved in that. In a future year, they may risk funding if they don't provide the data. That makes sense. That would be how I would address it.
My concern about not funding a navigator is that I'm using your iceberg. That we're right now, the nurse practitioner is taking that top piece, but it's missing all of the people who may indeed be the individuals passing around whatever is problematic. So it may be, who is the source of this particular infection within this group of people? And without a navigator to begin to find those individuals, to really get into the community and
seek out individuals for care, we're going to be missing opportunities that I think are, as you're saying, important to the success of this program, and indeed are the very individuals who may be at the heart of many of the health issues in the community.
So I think the navigator will have a prevention function, and just like Sarah said, in finding the people that need, that they may legitimately have a payment source for health insurance. They may get health insurance. They may not be on health insurance, but if the navigator can address that, we've solved preemptively a lot of healthcare access problems just right there.
Yeah, I think if we take away one of the tools that they need, then we can't really fully evaluate how effective the program is,
Whatever.
because it just, yeah, I know it's exactly what you said, but that's why I feel, Lisa, that I feel that we should fund it. I appreciate your difference. I appreciate also your desire to
So
save funds.
can we put in the contract then that either if we don't get, I just want that data piece to be there. And so I want that in the contract if we're going to proceed that fashion.
I think, but I mean, I guess just my opinion, but this is a contract for Health Net. So if we're wanting to require that from IU Health, I think this is the wrong piece to require that.
I think you just talk to Amy and tell her what you, she's working right next door, at least to the.
Have another meeting scheduled in January. We'll meet with all the people, go through all of the data collection. Here's the data analyst will be there, and we are going to have a regular scheduled meeting where we track the information. I don't think we can
In the
make
contract, we can't hold IU Health responsible in the Health Net contract.
Right.
Could you
that would never
convey
fly.
to Amy that it is the sense of the board that it's urgent to get the appropriate statistical reports in
I-
order that we can evaluate how things are going and possibly move forward with how you have.
To support the, you know,
I think that they understand that. And I think honestly that they're just as passionate and excited to kind of see how these services could make an impact.
yeah, I think, when I spoke to that Catherine Wiles, about a month ago, she was really kind of a little embarrassed that they couldn't provide any of this information, but she says, we have tried to get this, and we just don't have that kind of information. And she said, I'm going to send you what I have, which was that study, which really did provide a little information, but it was really,
Yeah, her embarrassment came through in the email.
yeah, exactly, yeah. So I think you're right, Lori. They are very excited about now being able to get more data. That data guy is really going to be busy, I think. There are a lot of people wanting things for different programs.
So I think that since, as I see it, this is part of our Health First initiative. Which KPIs are associated and are they delineated in this contract? That was a question I asked.
Access and linkage to care, you know.
Yeah, but I mean, have we specified which pieces of data we want specifically?
The ones that are outlined are the ones that are required.
I mean, they're getting blood pressure and different things, but I just didn't know if there were any other indicators that we are being asked for from the state that we should be delineating in this contract.
And I've had that discussion with them. So if there are services that don't directly align with one of those pieces under access and linkage to care, there's an other option, and I clarified with the state that can be entered under the other option. So if it is addressing chronic disease, or if it's just general paramedicine, like we prevented this person from going to the emergency department, that I enter it under that other category, and then just spell out descriptively what that is.
Okay, great, thank you.
And I'd also like to suggest, because I just think this is so cool, like you said, I think this is
Yeah, I think it's a great
fantastic.
concept and it's going to help our
I
community.
would love you to really make a big deal about it at the appropriate time, in the same way that you did with the video on the swimming. Because I just think that's so impactful. If we could make sure somehow, maybe not right this moment, maybe a year from now, that we make some cool marketing video and it goes out on the website and we make a big deal about it, because this is a big deal. It's really cool.
I think that this will make a huge difference. And I think
Yeah,
that
I do too.
6 months, a year from now, you know, we will be excited about like that swimming video.
Yeah.
And that all of that is important for us to make sure that county council sees, because we want and need their ongoing financial support in these programs.
So Lisa, what was you wanted something in the contract that required some reporting? Is that
Yeah,
right?
that's I mean, I understand it's difficult because it's involving IU Health, but I feel like it just has to have some language that we have to have data. And, you know, if that puts pressure on them to actually get data from IU, I just feel like that should be in the contract.
They're also going to be tracking all of the core service data though.
Mhm.
So we will have that, and then
Okay.
we'll all be collectively working with IU Health, like separately on that data. So I think there's two different data pieces that we're kind of talking about here. Some that's related to our requirements with Health First, and then some based upon the initiative about how this is going to reduce ED over.
But you feel like we'll be able to get data moving forward.
Well, let's
I
do
do.
this. Without adding additional language at this point, with the assurance that we'll get that information. But of course, if we don't get that information, we can make it clear that if you want to continue this program, you know, we have to have whatever it is that we aren't getting. Okay, does that
So that's
fair enough? I mean, we're,
Board meetings on a quarterly basis, when they do their quarterly reporting, we can just ask Lori, bring us the quarter,
Sure.
you know, give us a quarterly report. So then we'll all be aware.
so further discussion on the homeless initiative.
I move to approve the HIP contract.
It's been moved and approved to approve the HealthNet Homeless Initiative Program. All those in favor, please say aye.
Aye.
Opposed? Great. Thank you. Okay. Up next is going to be, we're going to go back in the agenda to have Nick from the Recovery Alliance. Love to have you. Good, always welcome.
Thank you. I'm sorry I'm late. We have something in the building and, the plumbing course for the first time in the city. So they're all under there. Some of my staff, some of the construction people, there's like 5 years, they've been there for 2 days. So like right as I walked out to come here, they were discussing what pipes they were gonna put in there and stuff. And I was like, more insulation, trying to get as much as I could. But
Nick, why don't can you come up to the tables just so you can make sure that you can be heard?
by the way, I will say that HealthNet has been one of our strongest partners. Like literally, they have done work. Their care navigators and all them have done, like, I would worry too about that. I love that you brought all that up. I love hearing all you guys are great. They are amazing actors. They, when they lost that person, we were flipping out because they were just in the field all the time, going there, helping us, helping them. Like we worked really intricately with them, you know, and it was because of them, we could get people care that we couldn't provide. Do you know what I mean? Like level of care that we could not do. So it's nice. I love that you guys are looking over the data. Also, it's great. I just want to make sure that, like, we love HealthNet a lot. They're amazing. We actually kind of scared when they're gone because we had new wound care. And so like now we're like, okay, we need nursing wound care. I got 6 of these done before I can get in here in the time. So if you guys want to make more, you can. If you want to share, these are just kind of a little small update. I have a full annual report getting ready to come out. I'm not rushing it. It's passed through.
I haven't seen you since you moved into your new place.
So we are getting ready for a grand opening, which you guys will all know. There'll be a soft opening with all of us. We have to pass through the construction stuff and get ready for it to be all the way, move-inable. You're not going to. So that's what happened. This has been like one of the best years we've had lately. This has been amazing. Lori, Kathy, everyone here has been amazing. I don't know if you guys know this or not, but I was raised in public health. My mother was a social worker. And so for us, public health care meant different when I was a child than other places. It meant that that's where we got our shots. That's where we got a doctor. So there's a piece of this that personally is real personal for me about making people not be scared of public health. Intrinsically, that's where I felt safe. You know what I mean? So like when we went to the clinic or whatever, I felt safe. It's what I knew. It's the people that cared for me. And so it's kind of a personal thing about that when you were talking about that earlier, like the eroded care in our government doesn't have to be in public health. It doesn't have to be that way. You know, we are different. And one of the things I like about Monroe County is that we are different. If I've been to a lot of national places now, like we are a different sort of people who really care, you know, and that's something that means a lot to me. So if you look at the bullet points are, we are open, as you well know, 7 days a week, and about 4,500 unique total encounters and 2,300 unique participants. That means like not a person repeating. So we have renovated and moved into our new building, and we began outreach in our new van. We have had, this is just reported, I'll get to this in a minute, over 1,000 reported overdoses reversed with naloxone we provide. That is above what the state has. This is peer-to-peer. This is when people who are using drugs are alone with their people that don't want money. That people do. It happens, you know? If you noticed, the first time out of any of our country, our state was 18% less overdose deaths. Our state alone. We have successfully, and are nationally renowned for this, saturated our state with naloxone. The Indiana Recovery Alliance provides almost 1/4 of all the naloxone that goes out the state. We are taking over a place called Ship Happens, which ships naloxone across the state. With that, we'll probably be one of the largest peer-to-peer distributors of naloxone, except for Overdose Lifeline, in the entire state. It is a labor of love for a lot of us, and it means more than you could ever know for us to know that people are being saved. But the simple thing of asking for something and arriving at the front door if they don't feel safe enough to go someplace, you know. We also are very happy to actually have Ship Happens come along with our team. So we'll now be doing mail-based distribution. You know, this means further access to people. This means creating stigma barriers that drop, discussing the narrative of what public health can be, all of these things. We just had our first I'm just gonna go over these quick and then I have a thing I want to talk about. We have a first AmeriCorps team member, so he joined as AmeriCorps for the first time. I was a little leery of AmeriCorps first because what I remember from AmeriCorps as a 48-year-old was much different than what's now AmeriCorps. These are job opportunities for a 24-year-old person who's been with us from all the way from a volunteer to doing some intern work to being an employee and then going out of AmeriCorps and being out in the public in the world to see what kind of stuff they can do in their lives and what kind of opportunities are open to them. And so they open a slew of wide opportunities to whatever this person who's Trin Pidera chooses to go with. So she is right now working on a point in time survey that we want to do for a long time. They'll give us an idea of like what's going on in our community in relevance to HCV, HIV, and any sort of bloodborne pathogens and a whole bunch of other stuff. It's kind of like I don't know if you guys know what point in time surveys. They're considered a better data than taking surveys every day. So we provided rapid testing. One of the best things of this year is we did a grant and we approved one of IRA's plans from the very beginning. You know, we helped create the ZIP Coalition. And one of the very first plans we had was that we know that it took one of us who experienced these things, who'd experienced prison, who'd experienced addiction, who'd experienced recovery, and it came out to help on the other side, needed to be at the lead of this. If we were going to get people treated for HCV, HIV, and to get people back into recovery, to get people living positively and healthy. So we started this grant with one person being a peer tester and going in the community and finding the people to test, and the other being a care coordinator out of Positive Link. It was monumental. Like we saw more people who had never been into testing than we ever had. We paid people $15 gift certificates from the grant to come just to get tested. So if you wanted to get tested, you get $15. We went to some clinics, whenever. Strange enough, we couldn't get to Wheeler because we were trying to get to Wheeler, but we just didn't get a chance. So I'm hoping we get there before the grant's over. We got to everywhere else. And it was alarmingly and wonderfully one of the best things that's ever happened. For a while, we didn't provide testing except for if they came in and asked. We didn't robustly do this because we could provide no cure. So we were hurting people by saying, here, you're positive of disease. We get you cured in a couple months. You can say that's okay, but that's not okay to tell someone. And I know from personal experience when they told me that, and I thought I could get cured, and I spent 7 years with a disease that they would not cure me of, was heartbreaking. And I almost lost myself, you know? And in being disabled and just sitting around on my butt all day going, I'm not worth anything, you know? It was only when I finally got cured by some people from this that I felt like I'm worth this, you know? And I could see what was going on. I could see a future, you know? This let people see that. All these people go into treatment. They don't just get served, they get tested and they go immediately into treatment. So within a week, you're getting people into treatment. This is unheard of. This is amazing. Other than having an actual like 7 gene expert, which is a point of care testing that takes 90 minutes, this hasn't been done very well before. We were hoping to do this further and incorporate telehealth, but the grant just is not, right, didn't have funding for it. So we're going to seek to do this through other funding. Out of 75 people tested in one group, 35 were positive. The epidemic is so larger than we think. It's so large. And people just don't want to get tested because they're scared. They believe old data, they believe old stigma, and they won't come in. I just can't tell you, like, from a personal basis, from suffering from this and having all this happen to me, like, what it was like to tell someone, no, you'll get cured within a week, just come back, or we'll follow you. So the peer tester would go find them. You know what I mean? If you're homeless, they went out to get you and say your meds are here. They went out to say, hey, come on for this, or naked confirmatory test. And, you know, I'm sure you guys see this, you help, but watching people get healthy is something that's like, it's unreal. You know, it's unreal to watch people. Not so much for me, but to know that like those diseases aren't being spread to other community members, that like this is a stop point, that we're aligned in the sand. So that was one of the best things that happened this year, and I love it. We also had the match grant, you guys, which, you know, as well as the county and the state really came together, the health department, all of us formed this like 3-piece that gave us this building, this van, and some extra supply money. We are now considered, when they put out the national standards, we had already done, without knowing any of the national standards, all of the national standards. The health department, us, and the county had all done it. So when they look at best testing, like the best thing you can know with opiate settlement grants, we hit every marker by just intrinsically doing it as a community, you know, which made me feel, and as I told them all in a council meeting, like I never felt like I was connected to my community in that way. I never felt like people were going to fight for me, you know. Having feeling like you have your county to fight for you is a huge thing, and my people feel that. And so that's transmitted into my population. When I speak to them, this was done by people who care that you live or die. That is probably the most important thing we can give people. The idea that someone gives a shit about you, that cares for them as they're going through the worst of their life, means more than you could ever know. It's what saved me, and it's what saves a lot of stuff. Hope is huge. It's powerful. I just want to say that because that grant provided something for a lot of us, especially us working in the field, that we didn't expect to happen. And we've all grown like a more sense of purpose. I know we in the health department have, I know that all of us have, of like, how do we look at this together? How do we move? How do we help people? And it's been amazing. We added an LCSW to our place, so we had an on-site counselor. There were things I couldn't deal with, and there were things that even people from training, they just don't have the capacity to deal with. And we needed to have that done both for workers and for people who came in. So when there's a huge problem or a crisis, we now have an LCSW who's on site. They're through another company. They're doing their own services. They provide free services when people don't have money. So it's not there's no cost to us whatsoever. The only gain they get is to serve the population. And so it's like one of the most robustly wonderful things we've had. So we now have, as an addition to this, all of our staff has group therapy once a week. By our own volition, you guys. I would have never chose group therapy. Do you understand this? Like, we chose to have group therapy as its staff. It's been like one of these things that we've had dirty, bad conversations. We've been hurt. We've been mad. But to know that we can come back to this place of like, of what I think it was a tribe, something my mother instilled in me. Like, I actually, for the first time, felt like I was doing her all right by being in a place. And it was the first thing that ever happened to me like that since she passed. It was like, I get why you did social work, Mom. I get it. You know, forever I fought against it. Like, I get it now. You know, like, personally, it was just. So we also acquired, we just became an RCO. So what that means is if we want to, as we move forward, which like we do, we're really close with the health department, Kathy and Lori and Melanie. As we move forward, we'll make this shape the way it needs to be shaped for the best for everybody. What it means is we're a recovery community organization. So peer coaching, NA, AA, harm reduction focused meetings, all become like a community building of sorts. So the idea that someone with chaotic use and someone 2 weeks into sobriety can operate and find positive change. People can see positive change going. They can see people working that are healthy in recovery, whatever their recovery is, MAT, sobriety, whatever it may be, and see there's a path in real time and know that there's a place safe for them. You know what I mean? We have a way to segment the entire SSP off. So that it literally can be, the building can be used without the SSP being seen by anybody. So people have problems triggering, it's immediately handled. We have, if you see it's a lot easier to see the thing when you see it. So when you see the building, you'll see what I mean. We designed this building to be the best place for the entire community. Right now, it's in two shapes it's in two sides because only one part of phase one has been done. When we get the rest of the funding for phase two, it'll be a robust building with like, partitions, but also wholeness togetherness. You know what I mean? The whole point is to like treat people without treating them as substance users. Do you see what I'm saying? If so, that's the only thing you get treated for in your whole life, then you're a substance user your whole life. If you get treated for your health, you come in there, you get treated for a stubbed toe, maybe your HCV. We can talk about the other stuff later. But you start to gain trust. People start to see with their eyes and touch with their hands recovery. They start to touch positive change. They start to meet people who are like, no, I did before, it's not right for me right now. Instead of, no, I'm not using it. They get to see things they can relate to. And they can understand that there's something they can have. And also, we might open the building up to someone who say wants a Zen Buddhist teaching class at 7 o'clock on a Sunday night. They don't have a place to do it. So the point is to have like robust services with also being a part of our community intrinsically. All these will be looked at. We'll probably have an advisory board and an advisory board. I'm real big on like openness. So to me, I want 8,000 eyes on everything we do in our community. The building was built by people in recovery. It was designed by people in recovery and staffed by people in recovery. That's not done. It's really an amazing thing. And
Are you gonna have an open house?
oh yeah.
Cause I'm excited
Oh, yeah.
to come see it.
We're gonna do something. You guys all get to go. Like where it's like this
I like that.
meeting, but yeah. So that everyone can see and all around. You guys can also at any time feel free to come by. It's not a problem. Just understand it's like under construction of your own volition. Again, it's one of those things that I wish everyone could have seen in the very beginning what it looked like. Lori got to say you can see what it looked like, and then you can see after it's all done. But like even in construction, it's pretty. It's like the idea that you can see the flow of like what it could be and what can happen is almost as beautiful as when it's done. On our board we have someone who is on the spectrum, and we did that intrinsically and importantly to provide this person with a sense that they're part of our community and that they're loved. They turned out to be like an engineer guru and like just like designed all this stuff that an engineer didn't have to do. Mind you, the engineer helped, but like it was unreal to watch this person thrive. And they then got kind of too much and they backed off. But like the idea that this person like designed a lot of our building is a huge point of personal pride for us. And a point of other pride that like people can be part of our community. They don't all have to fit the same bag. They can be anything and fit our community. We had a SUDAC summit that we had the SUDAC substance abuse. I don't know what's action committee, substance use disorder action committee, which is all people in the county, probation, law enforcement, like all in one group. It was really nice. It worked really well. I think the next time we do it, we'll have a more focus on people with experience and people in our group. Like I really want to do a recovery thing. That was a little bit, but it was really nice. Like watching our community come to it, watching people ask questions they'd never been able to ask before. Like that's probably my biggest point of pride is when people don't know anything and I get to explain it to them and then they get to like see that I'm not lying, which is a big thing for me because I had, times in my life where I wasn't that person. So it's nice to see this like other part. And yeah. And so if you look, there's a whole bunch of stuff here. It's just little things here. We have this mini pathways meeting right now, which is a harm reduction focused meeting where you don't have to talk about sobriety or anything. It's just about making positive changes in your life and talking about your substance use. Some people are not ready for that. They're not ready to go into sobriety, or they've been hurt by the NAA meetings. There's a place where they can go and they can say, look, it's okay with these things, provided a lot of us really good space. And we need to like not, talk about where your next steps are, how we can help another someone. It's been huge. Like we've had people come in that I never would have thought ever came into a help meeting. So it's for those people that like need a way forward without saying, without the NAA rooms. We also will have NA and AA and whatever anybody wants to at that place, because I think if you don't have that community there, then you don't have anything, So a big thing that we've learned, I've learned nationally is that like there's this kind of weird thing between harm reduction and recovery. And it's weird and stupid. And part of this probably is like me being at heater convention and talking to people who don't have heaters. But I hate that idea. And I think that the more of us in the fight are the more of us in the fight. So that's just my firm belief. I think that there's nothing without us, about us without everyone at the table, ever.
Well, I can tell you, the community is lucky to have someone with your kind of enthusiasm doing these. And or obviously organizational abilities to put this program together, and we have always supported it, and I couldn't,
Probably
I
always will.
can't see,
This-
I can't see anything that would stop us from supporting this in the future, because we felt like it's been well worth every penny we've spent.
Yeah, your support's been amazing.
Yeah.
Yep.
So, not trying to cut you off.
I know you got time. I got something to do. I know. I know I'm long-winded. Believe me, I've done this my whole life. I'm firmly aware of that.
Well, but I said before you even got here, I always look forward to your reports because, you're so enthusiastic about your program.
I tell people I sipped the Kool-Aid. Like, you don't feel like
You drank the
I'm a true believer.
Yeah, you drank the Kool-Aid.
Yep.
Does anybody have any other information or questions for Nick at this point?
This was really great. It's so impressive, and we're really appreciative of everything you guys are doing.
Yeah, I'm glad you had your new building.
Yeah, well, have you guys around? Like, it's really nice to be wrapped with you guys. Laura's been amazing. Kathy, you guys have been amazing. Like, it's been nice to feel supported in that way. Like I said, it's something I never had, and because I was in different places in other lives, but like, it's been nice to feel like I can say to people, my community's behind me. That's been something I've never been able to say for
Well, we certainly see the value in it.
And we're excited to go see the new
Yes.
building. When we're invited, I think we'll all show up.
We're hoping to. I'm not saying anything because last time we thought we were gonna get in there, and then like some other stuff happened, and the building got, if you've ever had a building or a new house, but it's a surprise every day. And we're outside surprises, because darn it, like, stress can't take another one, but it should be here. And like I said, we'll call you guys in the health department probably before anybody else, hope you guys in. We'll get it, take it.
That would be awesome.
Yeah.
Thank you, Nick.
Very good.
Thank you guys.
Thank you.
Thanks, Nick.
Yep. And you guys will probably get your email after I send it together, a full one that's like budgets, numbers and stuff like that, whatever that says kind of what's going on and nuts and bolts, and you'll a little bit more understanding about RCOs and stuff.
Correct.
If you ever
That's
need
great.
anything, you can always email me.
Thank
Okay.
you.
Thank you guys.
Thank you.
Have a good holiday. Thank you.
Thank you.
All right, let's move on to the IU Health Public Health Clinic contract, the much discussed and I can't tell you how many hours. Yes. I'm hoping we can wrap this up
Just move
tonight.
to approve, and we can be done.
Nick,
Oh,
Hey,
did you
Nick.
Forget something?
you got your coffee.
You can't travel anywhere without that.
Yeah, that's right.
My life was right there. Thank you guys.
See you.
Nick,
Okay.
Because we've really worked on this puppy.
Yeah.
When I sent out the email explaining what the proposal that Laura and I came up with, and that Laura, after our meeting with them, do we need to discuss this further?
yes.
Okay,
So I feel that I'm just not satisfied with the VaxCare. It is entirely unclear, exactly how much money is coming in, what IU Health is making, what the line items for the budget are, what we're spending for VaxCare, and what that looks like as a whole piece.
well,
So-
Lori can provide information on how much VaxCare, exactly the number that VaxCare is coming in, and how much we've paid them, that type of thing.
Okay.
Oh. Yeah.
So I received this. So is this,
That's what we track on our county financial side, because we receive the VaxCare checks and then we process them and then make the payments to IU Health.
so is this information ever presented in more of a budgetary form? Like here,
On what they are using it for.
right,
Like
fun?
I think some of that may have been in one of the Excel documents. I'd have to clarify how they are tracking that on their budgets.
So I guess everyone feels clear that, okay, this money is coming in for vaccines, and then exactly how that money is being, or exactly the budget, how money's being spent. I guess it just feels very unclear. And so therefore I still have issues with the 80-20. I know that's just been how it's always been.
Their point was they didn't understand why it wasn't all coming to them. That was the first thing they said. Well, yeah, we never really understood why we're not getting all of it. I think in their view, they're doing all that. Here's, I get it. Trust me, I'm not not standing in your way here of asking these questions, but I think in their view, they're doing the work, and there is a budget shortfall every year, and if we took away the Vax Care program, that would be bigger. And so they would just
We
be,
have to give them money.
so we would just be adding more money in the contract in the other part of the contract. So the current arrangement, I think, continues to be evaluated, but at this point, I feel maybe like you, not completely certain exactly where their VaxCare money is going, where it's going, but I know it's going to cover some of the things that aren't covered by our other contract, which obviously they were asking for a much higher amount. They weren't asking, actually. It was Amy said when they sent that over, it just reflected their actual expenses, not in personnel, not really what their expectation was, or they were used to an increase more in the range of, well, last year, I think their increase was like almost 10%, right? So in view of that, I felt like there was not an obligation on our part to provide a big boost simply because they had the number down. So, and they said that, they were more in line with like a 3 to 5%, 2 to 5% increase. I think that's what they actually said, if I recall correctly.
So we left that meeting feeling like we still didn't have a completely clear handle on the 80-20 for VaxCare, but we felt like it probably made sense for them to at least keep the 80 after we talked to them, because it's all going for vaccine administration, which they do and we don't. So, and I think, just speaking only for me, when I'm on a board like this and I'm looking at all of these grants and all of these things, I have to go, what's the point where the juice is not worth the squeeze? And so I just don't think there's enough money here for us to be talking about, is it 80-20, is it 70-30, and getting down into the weeds of every single penny of what that's going for. Like, I'm totally willing, at least this year, to just say, yeah, they convinced us they need it. They're doing a great job. Let's just move on. We got bigger fish to fry.
Mhm. So my point is just accountability. Like, if we just have all the information, then I'm okay to make decisions, but I just want all the information. And I feel like, we started back in August. I started asking for information, and it's taken until the last hour in December, less than a week ago, to get more information. So I just want, I guess taxpayers should be able to say, they look to us to be able to say, okay, here's what things look like. And, does that appear to be, bean counting, if you will? I think that's fair. I mean, I think we're stewards of taxpayer dollars, and, I agree with vaccines. Obviously, this is important for our community. I'm not arguing about that. I just.
No, I think we understand your point.
Yeah. So.
Yeah, I mean, and it's not that we don't,
So I'm
it's
not
not that we
trying to
disagree
argue.
either.
Yeah. We don't disagree. I just think they're different approaches, and I wish we had started all of these grant renewals earlier in the year. We should not be in the middle of December in the position of having to review and approve grants that start January 1st. So I'm hoping for next year, we can start this process much earlier and work out all of these things so that we're not in this position, but right now, here we are, and it's really down to,
Plus,
you
we'll
know,
see,
we let an agency this important go without a grant January 1st because we didn't get a sufficient answer to
yeah, we can start,
Vax Care. Well,
yeah,
no.
we can start, keeping track of the VaxCare dollars and have it in a, you know, some report. And like I said, if it continues, it's been irregular. So, the last 2 years have been pretty good, to the tune of like, what, 60 something thousand? But prior to that, I think it was,
Under 10.
yeah. So not, it's become a little more significant, and that's why I said in my email that, we would track this more closely, and if the trend is to remain high, pretty substantial, then I think, we want to take a closer look at what the distribution level is.
But I think what they told us is that it was that high during COVID and because they were doing way more vaccinations and they don't expect it, barring another pandemic, which nobody wants. They don't expect the levels to get up that high anymore.
Could just request like financial statements about some of that reporting when they submit their outreach and reporting. I guess that's.
Are we able to get that kind of reporting quarterly so that we're not at the end of December looking at the numbers that we really want?
Yeah, I think that I can ask that. I think that's probably certainly reasonable. The VaxCare checks they don't come on a consistent basis though. So
Yeah,
they're always infrequent. We never really know when they're coming. So, I
I
mean,
would
one
think
quarter.
since a lot of vaccines take place in the fall, that you're gonna get a lot of money end up at the end of the year.
Yeah.
But can we actually look at the number of people, the number of incidents of vaccination from IU Health and be able to track that, so that we have at least an idea of, okay, all this money is going into VaxCare and we're paying for these employees who are purportedly doing all of the vaccines, and how much of their time, effort, I think that's what I'm hearing is the real issue here, is how much of the day of a nurse's day and work is actually administering the vaccine?
We asked that question.
And we're not going to get an answer.
No, we did get an answer. They said virtually 100% of their time is spent doing vaccines. That's what they said.
Well, that's true for most public health agencies in the country.
And
They primarily do immunizations.
So do they charge a copay for that? Do they charge some patients their insurance
I
copay,
don't think
right?
so.
They bill.
Well, the insurance, yeah, but not out of pocket. I don't think they charge people that don't have insurance.
Not.
But they are collecting some copays and billing insurance.
I don't.
Yes,
I believe they are.
Yes, they are. I mean, I think patients who show up, if they have insurance, they bill their insurance.
They
What's
bill
different
my
than
insurance,
collecting
but
the
I've never
copay?
paid a
Yeah.
copay.
Immunization should not have a copay.
Yeah, that was what I was thinking. I wondered if immunizations would.
I wonder if we do move as Sarah has suggested to something like a quarterly reporting system, whether we could get something a little less opaque than
Oh,
this stuff,
sorry.
like maybe a budget.
Well,
You know,
cumulatively.
Yeah,
okay.
cumulative, because as Lisa points out, it's not really too helpful and hard to understand.
Yeah, and that's just our internal financial tracking here.
Oh.
So we can see that on a spreadsheet and it makes sense.
so do we need to put in a contract what we expect from IU Health?
Or can we just twist their arm and say, please give this to us?
Well, we've tried twisting their arm since August, and then here we are at December, so I don't,
We need to send this out. We need to have a signed contract
Well, I understand that.
Yeah,
But
today, I mean, we
it
need.
needs to
yeah.
be
In the
right.
future,
I wouldn't be, I wouldn't disagree with that, maybe need, we could, I think because the leverage we have obviously is that the clinic depends on this grant. And so, we could just tell them what we need to have done, what we need.
Okay, so.
I don't know that it needs to even be in there. I mean, basically, they need this grant.
So could we make an amendment to the contract that says that within 90 days, they have to provide a line by line budgetary explanation of income and expenses from last year? And that they have to have that within 90 days so we can start to make decisions moving forward?
it's a little late to my.
I'm not in favor of asking, making any changes in this contract as it is today. If we want this information in the future, then I think we just need to make it clear that we have to have it.
Otherwise, we can't approve another
Right,
contract.
exactly. That, but that's what I say is that's the leverage is that I think they'll be more than willing to provide basically any information that they have the ability to provide. Whether that will be still exactly what you want, I don't know. But I'm hoping that I don't think it needs to be in the contract in order for us to get what we need.
Can
No,
we
I think they're
convey
very
it to
willing
the
to-
contractor that the sense of the board is that we need to have better reporting on these data? And that more frequent reporting would be appreciated too. And otherwise, we have difficulties going ahead with our planning and approval process.
Because all of the things that we ask for in reporting are about, who's being treated
They're
and,
programmatic, they're not financial.
and we're making this, well, it says when receipt of a properly executed claim voucher and monthly financial and activity statistical report from the public health clinic. So maybe we need to explain that this monthly financial statistical report needs to be specific and not generalized. I mean, does that help get us where we want to be?
Yeah, we get lots of reporting and financial breakdowns that we submit with the grant, so I think it would be similar to just simply asking for that same type that includes like the max care.
So do we have further discussion on this at this point? But I would call for a motion to pass the contract as it's.
And I'll second, and then we can squeeze and twist arms and.
It's been moved and, yeah, that's right. It's been moved and seconded to approve the public health contract. All those in favor, please say aye. Aye. Opposed?
No.
Okay, motion passes.
And then we have an agreement in our packet, but it's not on the agenda. Do we need to vote on this agreement for coordinated school health services?
Yes, I'm sorry about that. So so you did actually vote on this the last time we met, but I had a request from one of the commissioners to be able to expand our school liaison services to include pre-K. So ECC, SC, and RBB. So that'd be around 100 children. I was able to speak with Amy, and so the only change to this is that it does account that these services will include pre-K.
Okay. Mm-hmm. I move that we accept the agreement for coordinated school health services.
I'll second.
It's been moved and seconded to approve the school liaison contract. Is there further discussion on that? Hearing none, all those in favor of the motion, please say aye.
Aye.
Aye. Opposed? Motion passes. All right, that concludes our old business. New business, officer elections. I have asked Aurora, our vice president, if she's willing to do the president's job. She has.
And she's still rolling her eyes about it.
And I asked Dr. Robinson if she'd be willing to serve as our vice president, and she indicated that she would. So I am, I suppose we should vote on these separately. So do I hear a motion to, I'm not, or Aurora is nominated as president.
I'd like to move that we accept both of those as a package and that we do it unanimously.
Thank you.
I'm not sure exactly what you said, but.
Yes.
Do we have a second?
As an expression of confidence of the group. Yes.
Okay.
Very sweet, thank you.
All right, all those in favor of accepting the ticket?
The package.
The package deal?
Deal, package deal.
Please say aye.
Aye.
Opposed? Well, congratulations, both of you. I look forward to your
Thank
administration in the
Sure, we'll do our best.
near future. Yes. And our final item on the new business agenda is that Dr. Britton has decided to resign as medical director. I want to thank Dr. Britton for his service, and certainly when he took the job initially, he accepted it on a practically an emergency basis.
Practically.
Well, Dr. Sharp became apparent that Dr. Sharp, who Dr. Sharp had served the department well for many, many years, and there were some changes taking place in his health, and also he didn't have a DEA number, which we were struggling with the max care billing. So Dr. Britton kindly accepted that position, and I think he really didn't really understand. Well, I'm sure he didn't understand exactly
What the expectation.
what the expectations are. Well, I know he didn't because, and I'll take some of the responsibility for that. We probably didn't spell out in detail exactly what we needed him to do, but he had very graciously continued in the job, even though he was being pulled back towards his practice and other activities. So, Dr. Britton, thank you very much for your service.
Thanks for your support.
You're here.
Yeah, thank you.
It's been a bit of a challenge, but mostly rewarding and exciting at times.
I could,
Does the board have to?
it's kind of like being chair. It's mostly rewarding, but.
Does the,
Mostly didn't want to kill myself, right?
does the board have to accept the resignation?
Yes,
I think we do.
yes.
So I'll move to accept the resignation.
Second.
It's been moved and seconded to accept Dr. Britton's resignation as health officer. All those in favor, please say aye.
Aye.
Opposed? Thanks again, Clark. Appreciate everything you've done.
Thank you.
The last piece of this would be that we obviously need a new health officer. And Dr. Sarah Reiterband, one of our esteemed board members, has accepted the responsibility, at least on an interim basis, because we don't make that decision. We simply make a recommendation to the county commissioners, and they appoint or have the contract gone out. So that's something that Dr. Reiterband will be engaging in the near future, very near future, like immediately.
In which case I will then
And I
submit
think-
my resignation.
Yes, and then also we will have a vacancy, which we've perpetually had, but we'll have additional vacancy on our board when Dr. Reiterband resigns to become health officer. And I will just say for an open, just full transparency, I, on my own, talked to Dr. Lee McKinley, who presented to us last month, just casually asking if he had any interest, which he does have interest, but he hasn't given me a yes or no. And I realized that I did this because I felt like he would be a good board member and obviously takes a great interest in the work that we do. And you could tell by he has a passion for it, basically. Mm-hmm. And so I pointed out to Dr. McKinley that even if he decided to do it and we recommended him, which I didn't say that, I told him I didn't have the ability to recommend him just by myself. So that the commissioners, again, have the final decision. So that at least something's in the works here.
What are the requirements? Does it have, it has to be a physician or a healthcare provider?
I think that seat has to be a physician, and
We have
our
two physicians.
other vacancy has to be
Done.
the mayor's
Done.
appointment.
Okay.
And
Mayor's appointment.
someone that lives in the city limits.
Yes.
And we thought, do we have any information from Amy about that person? Because we had a healthcare provider who was a Republican who could be appointed by the mayor.
Yes,
And
and
she was
also
gonna find out if
Dr.
they-
Britton gave me the name of a physician, Jim Ferris, I believe, Jim Ferris, and I have passed that information only recently on to the mayor's office, so.
So we've got two. No.
So if the person is the DEM and has to be a physician or a nurse practitioner or no?
I don't think so.
I
No,
don't think that was in the,
I think there's
I'd have to go back and read it again,
But they have to be in the
but they're very,
city limits
no,
for your,
for the Bloomington
Oh,
one
right.
now.
The mayor's appointment has to be a Bloomington
Right.
resident.
Like they list, like somebody has to represent, somebody has to know something about public health.
oh,
There has to be a physician, there has to be, they name,
right, there's a
an
list,
Indian chief and a
list of people,
baker and a.
and it's an
yeah.
expanded list from what it used to be.
in SB4, it was much broader than it
expanded, yeah.
has been.
so I know of a nurse practitioner who may be interested also.
Okay,
Um,
Well, that would be good.
so,
That would be good, because we need more. We need
so I don't know how that, like, do people apply or?
would this be, would she fit the bill for the mayor's?
No,
also-
she doesn't live in the city limits, I don't think.
Okay,
Yeah, and she's a DEM. Mhm.
okay.
They applied through the commissioner's office.
Okay, yeah,
Right.
got it.
One of the candidates that we had recommended, it was a political thing that they said no. It was supposed to be a Republican, but at one point, this person had apparently declared,
Well, that was
Democrat,
Daniel Milliken,
that was why they,
Lisa's, but some,
And I was unaware of that. But
well, yeah, but wasn't there something that happened after that? You got he was
Well,
certified
they need
as,
to go to the Republican.
He was
chair.
certified by the Republican chair.
But I think they have to vote several times in that.
In the last two primaries.
But
Right.
he was then
With one party.
certified by, that he was a Republican in good standing by William Ellis.
And that's important, but still, as George
Well,
says,
what, didn't they
Meets
have,
the criteria.
but didn't
I
they
think-
already, but they already had his name and information,
Right.
right?
But I think they decided not to forward or not to recommend him.
I see.
Mhm.
Okay. Yep, I wasn't aware of that, actually, that they decided not to do.
I mean, I assume that's what happened because they had it and he met the criteria and here we are.
It's still, okay, right. Well, obviously they did,
So do we need
because they
a
had his
motion?
information.
Yeah, would it be
Sarah?
appropriate for us to vote as a health board to endorse the application of Sarah?
Oh, absolutely. I think we should.
If so, I with warmest regard.
And I would
Make
love
that-
to second.
There you go. So it's been moved and seconded to put forth the name of Dr. Sarah Ryderband as the Monroe County Health Officer. Put this forward to the commissioners for their consideration. All those in favor, please say aye.
Aye.
Opposed?
I was an I. I was an I.
I just happened to be looking at you.
You did.
All
I
right,
look forward
the motion passes.
to working with my former board members. Should
Someone-
What?
Did you have something in comments that you wanted to?
I
Bring up.
did, I wanted to.
I do. Sorry. Continue.
Okay,
Okay.
go ahead, please. No. One of the things that came before us was the neonatal program at Health First. And since we have
Health Net?
HealthNet, sorry, since we have stepped back from the contribution we were making, I would like to remind the public that this is a time of giving, that HealthNet, like many of our partner organizations, for instance, Indiana Recovery Alliance, are not-for-profits, and your funds are certainly welcome to any and all of our partners who help the health board do the job of public health in our community. So give generously.
Thank you. Well-considered comments.
I'll make it brief. I just want to challenge us to start to think about our goals for our community for the next year and really start to talk about those at the next meeting. I know there was a big meeting with, statistics and there's going to be a report and they're going to say, okay, here are the things that we should work on. I think there's no reason why we can't, as a board, say, make our own decisions about, hey, this is what we have the staff for, this is what's important for our community. And so I think one of those, it should be chronic disease management and maybe revisit the mobile unit to go out into the community to do that. So I just want us to be thinking about that and really be able to, January when we meet, start to hit the ground running and not, be independent as a board. And we have some new staff. And I just look forward to making our goals for the year and improving the health of our citizens.
Amen.
That's all I got.
Thank you, Lisa. Dr. Britton?
So I don't know if the board wants to do this, but I'd like to have some comment about Cheryl Munson, who passed this week. Who's gone for 2 days ago, she passed.
Oh, I didn't know that.
Yeah.
Yes.
So if you'd be interested to make a comment as a board, she's been very supportive,
Yeah,
staunch community
well,
supportive.
maybe you'd be best suited for that
Yeah.
Well,
because,
she's a neighbor and a friend, and we're
Yeah.
already doing that, but I'd be glad to convey that for the board.
thank you.
But it might be nice to send a letter to her husband.
Oh, yes,
To the council or,
yes. Okay, we can do that.
Yeah.
Yeah, I'll help. Well, I'm still president.
You'll
of the interview,
do
so
that.
I'll take it.
No, I only met her a couple times. I'm not, you should do that.
Condolences from the board
Pardon?
to,
think her husband.
to her
No, 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 no.
family.
Yeah.
Not?
no.
Oh, yes, he is.
Pat's, yeah, he's
So-
not that well,
So
but
condolences from the board to her family,
yes.
from a board that was well supported and cared for by this amazing county council member who cared about this community and the health of this community.
Strong
That's
advocate.
sad.
Yeah, too sad.
Thanks for
She,
mentioning that.
She got sick, she had urosepsis and some other things, went to Beltrais. It was kind of convalescing, and she had a cerebral event and
Oh,
passed.
goodness.
It's kind of been
very sad. Well, I just want to make a couple of comments. I want to thank the board for its support during the last year and a half. They haven't been the most pleasant at times. But overall, I feel like we guided the department through some of the very difficult times, and I feel like it's on a sound footing. And I'll give a lot of the credit to Lori, who I think is an amazing administrator. And she's had to put up with a lot of things, well, from me and from the public, but actually, I'm going to thank you for all the hard work you've done. And I know it's been a little discouraging at times, and you felt really like underwater, but
Yes.
But we appreciate you.
Yes.
Yeah, we really appreciate you.
yours.
And I want to thank you, Steve, because you have gone above and beyond and have put in so much time and effort. I'm
Well, thank you.
immensely grateful.
And I'm not saying goodbye to you because I'm still going to be leaning on you. Just so you know, Steve said he was going to help me a lot.
Good.
So I'm going to be depending on him a lot.
I'm here for you.
Thank you. I know. Thank you.
Thank you indeed, Steve. You're our go-to guy and have been for this whole year, pretty much.
Thanks. Appreciate that.
I don't know if I can do it without you.
You can do it. With that, I would accept a motion for adjournment.
Move to adjourn.
Second.
All those in favor? Aye.
Hi.
Opposed?
Happy holidays, everybody.
Yes.